Welcome to Epilepsy Management and Beyond. My name is Donna Avanecean, and I will be your presenter today. Welcome. So if you have not already viewed my previous presentation, circuit breakers and epilepsy, please do so as I go into more depth about the diagnosis of epilepsy and provide you with a overview of treatment. Today's presentation will be focusing on medical management and surgical management of persons with epilepsy. So to begin, I'd like to share a little information about myself. I have over 30 years of neuroscience experience. I have various subspecialties, including neuro-oncology, neurovascular, epilepsy, and movement disorders. When I'm not functioning as an APRN provider at the Epilepsy Center for Ayers Neuroscience Institute, my other hat or role is the current director for the Hartford Healthcare Medical Group Advanced Practice Providers Specialty Division. I provided you with my email address, and please feel free to contact me directly if you have any questions or recommendations. Okay, so for the objectives for today's presentation, we're going to be discussing the medical management of patients with seizures and epilepsy. I have nothing to discuss. I'm going to begin today's presentation by discussing the principles of medical management of both seizures and epilepsy. So anti-epilepsy drugs, AEDs or anti-seizure medications, ASMs, as they are referred to, are primarily metabolized by the liver and are excreted by the kidneys. How we select a particular medication for the treatment of seizures and epilepsy is going to depend upon the seizure type that we believe the patient has, and of course, potential side effects. Also, I would add any other comorbidities also will play a factor into which medications we try to avoid. Do know in as far as principles that dose-related side effects are very common and usually resolve spontaneously or with dose reduction. We do, to a certain extent, follow therapeutic ranges. Sometimes I will employ therapeutic ranges more so to determine compliance. Or it sometimes will aid me in allowing for me to up-titrate, even though it looks like the patient is at their maximum dosage. Having a therapeutic range on the lower side will allow me to increase a medication dose if necessary. Some common, because you're going to notice that when I go through the medications today, I am not going to review their dosages and their potential side effects. This is something that is easily accessible through either UpToDate or whatever pharmacology references you use. But if you were to, poll all of the information out there regarding side effects with anti-seizure medications, there is a very large common denominator, and that common denominator is GI upset, whether that's, nausea, sometimes vomiting, just GI intolerance with diarrhea, not so much constipation. The majority of the anti-seizure medications are weight neutral, except for medications such as pregabalin, gabapentin, and Depakote. Keppra is usually listed as being weight neutral. However, I have had patients who have sustained weight loss as well as weight gain while on this medication. Other side effects include dizziness, nystagmus, dysarthria, diplopia, ataxia, skin rashes, which can be as benign as a mild macular rash to the extent of being severe, such as with Stevens-Johnson syndrome, as well as Dress syndrome. Lamotrigine and Keppra can both lead to either of these. Lamotrigine generally tends to cause Stevens-Johnson's, and Keppra can cause Dress syndrome. However, there are some cross sensitivities between lamotrigine and carbamazepine and oxcarbazepine, so that there may be a cross reaction, and you may also see a Stevens-Johnson-like rash with those medications as well. Combining two anti-seizure medications within the same classification is usually avoided, especially with the sodium channel blocking agents. So if you look at the side effect profile of a sodium channel blocking agent, this can have a negative impact on the heart, causing cardiac arrhythmias and changes in the rhythm. And so you would never want to combine two sodium channel blockers, as your rate or risk of increasing for those cardiac changes is going to be higher than if they are on a single sodium channel agent. And one of the other principles or take-home points in regards to the anti-seizure medications is that all will have some degree of fatigability and daytime somnolence, which we'll talk a little bit later on when what some pearls I have as far as switching patients from immediate release to an extended release formulation of some of the medications, which may help with the fatigability and daytime somnolence. So we classify anti-seizure medications by specific classes, such as sodium channel modulators, calcium channel modulators, alpha-2 delta-1 calcium channel modulators, aminobutyric acid modulators, fructosamines, and methyl D-aspartate receptors, and alpha-amino-3 hydroxy-5 methylosoxazole, or propionic acid receptors. And then there are a handful of anti-seizure medications that really do not fit into one of these classifications or categories, and we just have a overriding sort of heading of other. We'll begin with our sodium channel blockers. These are very commonly used, most of which you're probably already familiar with. And when we look at each of these anti-seizure medications, we look at it in the four major groupings of types of seizures that they will be effective against. So it's either focal, generalized tonic-clonic, absence, or myoclonic epilepsy. Now, phenytoin, which of course has been around, since I would, if I can recall correctly, either the 40s or the 50s. This is an excellent anti-seizure medication. It is very effective against individuals with focal epilepsy. Even though we say that there's a possible effectiveness against generalized tonic-clonic seizures, years ago, before we had Keppra and other medications, phenytoin was the mainstay of treatment for persons presenting to the emergency room with GTCs. They would get an immediate acting benzodiazepine to control the seizure, followed by a longer acting anti-seizure medication such as phenytoin. And that was the great thing about this medication. It comes in multiple formulas. There's IV, there's the capsules, there's the chewable infatabs, there's sprinkles. And so this has been, an excellent drug for many, many years and is still used till today. The usage of phenytoin in the treatment of absence seizure, which is another type of a generalized seizure, is generally not used, as well as in those individuals who have myoclonic epilepsy. The downside to phenytoin, it has a nonlinear pharmacotherapeutics. So increases or decreases in a dose will not have a linear metabolism. And sometimes, you will chase the therapeutic ranges and too quickly will increase the dose of the medication, understanding that the pharmacokinetics of the drug is nonlinear. And what can happen is you can wind up making very small changes in the dose of phenytoin, which will then yield a very high supertherapeutic drug level, which may lead to various side effects, including nystagmus, dizziness, diplopia, and somnolence if it's high enough. Fosphenytoin is a pro-drug to phenytoin. It is basically a hydrantoin molecule with extra molecules attached to it. So it behaves a little bit differently. It doesn't have some of the horrible side effects that phenytoin is. And I failed to mention with phenytoin, one of the biggest thing is gingival hypoplasia and bone loss leading to osteoporosis. But fosphenytoin is very useful. It's on many hospital formularies. It has an IV form. It can be given in an ICU or inpatient setting. It is very useful for those individuals presenting with focal seizures. There is some possible efficacy in individuals with GTCs, or again, I can tell you, as with the phenytoin, it is usually used in the emergency setting. Patient again will receive a short-acting benzodiazepine followed by an IV load of an IV anti-seizure medication, such as fosphenytoin. Now, I mentioned that it does not have the horrible side effect of phenytoin, in that when phenytoin is delivered intravenously, it must be delivered very slowly. 5 to 10 milligrams per kilogram is usually the dosage, and you want to give that total dosage extremely slowly over a period of probably about a half hour. If you do not, do note that you could send the patient into a rapid cardiac arrhythmia leading to death. And I have observed this. So with the fosphenytoin, although it still needs to be a controlled drip, it does not have the nasty side effects that phenytoin does if given too rapidly IV. Now, carbamazepine is another sodium channel blocker or modulator, I should say. And this drug has been out for a very, very long time. It is useful in the treatment of persons with focal epilepsy. Again, there is some possible utility in individuals with GTCs, although as with our fosphenytoin and phenytoin, I can tell you that carbamazepine for many years was used in the treatment of generalized epilepsy. As with phenytoin and fosphenytoin, this would not be prescribed in persons diagnosed with absence or myoclonic epilepsy. Now, one of the newer medications, eslicarbazine, which is a derivative, if you will, of carbamazepine and oxcarbazine. So if you think of carbamazepine as the first agent, and if you look at the second agent that came out in this same family, meaning that the base molecule is the same, that would be oxcarbazine. And then the third generation of this medication is now the eslicarbazine. The trade name or the brand name for the medication is called Optium. The nice thing about this medication, it can be given in a once-a-day dosing. Phenytoin and carbamazepine, as well as oxcarbazine, do require either a BID or TID dosing schedule. Again, with all three of these, well, primarily the esylcarbazine and the oxcarbazine, the effectiveness against GTCs is essentially unknown. However, you would not prescribe this medication in individuals with absence or myoclonic epilepsy. Next, we have lamotrigine. This is an excellent drug. The only downside to lamotrigine is that it does take 6 weeks for an up titration to get to a steady state dosage. The reason for this is that within the first 6 weeks, we have to taper up very slowly over a by 25 milligrams over this period of time to avoid the development of Stevens-Johnson's syndrome. Usually, once you start getting them beyond the 6 weeks, you can do a more rapid taper up if necessary. This is an effective, very effective anti-seizure medication in both individuals with focal epilepsy, generalized tonic-clonic seizures. There is some possible effectiveness in those individuals with absence and myoclonic epilepsy. Now, lacosamide, which has been out for many years now, is also a sodium channel blocker. It's very effective against focal epilepsy. Although the effectiveness against GTCs is essentially unknown, I can tell you that very frequently, as with the oxcarbazine, esylcarbazine, and carbamazepine, we do use this in individuals with generalized tonic-clonic seizures. Lacosamide does not have any, should not be prescribed in individuals who have been diagnosed with absence or myoclonic epilepsy. Now, there is a newer agent, which I do need to add to this slide deck, and that medication is called cenobamate. This medication came out several years ago. Its primary FDA approval for treatment is in individuals with focal epilepsy. There are current studies that are out there right now in examining cenobamate and its effectiveness on generalized seizures. And of course, there is no literature out there yet identifying the effectiveness in those individuals with absence and myoclonic epilepsy. I would believe that later on, after the research is completed on its effectiveness against generalized tonic-clonic seizures, there will be other further studies examining its effectiveness against the absence and myoclonic epilepsy. Cenobamate, similar to lamotrigine and lacosamide, requires that you do have a knowledge of a history of any heart issues, cardiac arrhythmias, any AV blocks and such, because the sodium channel blockers will directly affect this. So in individuals with family history of changes in the AVR, this medication should be avoided, and I would include cenobamate in this as well. Cenobamate also requires a 12-week up titration with a maximum dose of 400 milligrams. It's usually very well tolerated. The majority of sodium channel modulating agents, you must follow their serum sodium levels, as hyponatremia is frequently seen with this classification of medications. I also mentioned with phenytoin, besides all of the other downsides with the bone loss and the gingival hyperplasia, examination of the liver function testing is also very important. Now, the next classification of medications that I'm going to be reviewing are both the calcium channel blockers as well as the alpha-2 delta calcium channel blockers. And so when we look at the calcium channel blockers, we're looking at zonisamide and ethosuximide. I'm going to start with ethosuximide because the uniqueness about this medication is that it is only employed in individuals who have been diagnosed with absence seizures. So there is no effectiveness, nor should it be prescribed in individuals with focal, generalized, or myoclonic epilepsy. Now, zonisamide, on the other hand, does have some possible effectiveness with GTCs, absence, and myoclonus, but primarily its effectiveness is against focal seizures or focal epilepsy. It is an easy drug to up-titrate. You usually start at 100 milligrams and can go up as high as, I have seen as high as 600 milligrams. You do have therapeutic level that you can obtain, and that can be used as a guiding principle as to whether or not how high you can drive the zonisamide dosage up. Overall, well tolerated, as I've said. The only downside that I have seen to this medication is in individuals with history of kidney stones. I try to avoid it. The second is that it can cause diarrhea. So if anything, that is a big complaint when patients are taking this medication. Now, the alpha-2 delta calcium channel blockers work a little bit differently. The two main medications that are within this classification are very familiar to everyone. That is gabapentin and pregabalin. These are considered to be weak seizure medications. However, they are still used. I very rarely see either of them used as a monotherapy drug, but more so seen as an add-on, as a second or third anti-seizure medication. Of course, they're both excellent pain modulators. They both work against focal seizures. Generally are not useful in individuals with GTCs. And in fact, gabapentin can make absence and myoclonic epilepsy worse. And with pregabalin, that could also make absence seizures worse, but you would not use this type of medication in the treatment of myoclonic epilepsy. Now, our aminobutyric acid medications, of course, our oldest one on the list is phenobarbital. This accidentally, by the way, was found to be useful in the treatment of persons with epilepsy many years ago, many moons ago. It was initially approved in the effectiveness against individuals with behavioral issues. We still see the medication used today. It also has, as well as with phenytoin and the carbamazepine, has some downsides, including the fact that it can cause bone loss. So you, with the phenobarbital as well as dilantin and carbamazepine, should follow patients with DEXA scans. Phenobarbital is excellent in its effectiveness against focal seizures, possibly GTCs, although, back many years ago, there weren't much of a choice. So phenobarbital could be used in the treatment of GTCs. This is not useful with absence seizures, but fortunately is very helpful with myoclonic epilepsy. Usually started in childhood. There is some discussion, as a side effect, that it can affect the child's IQ as they're growing up, but it is a very effective anti-seizure medication. We have clonazepam, which of course is Klonopin. It is very useful against both focal and generalized seizures. We use this more so as a rescue medication than an actual treatment medication. but I have seen it used as treatment line therapy as well. There is some possible utility in individuals with absence seizures, and this is not a medication that would be considered useful for myoclonic epilepsy. Clobazam, which that's the trade name of ARNP. This is developed. This was developed several years ago. Very helpful against focal epilepsy. Some possible utility with persons with GTC and absence, but not usually useful for myoclonic epilepsy. We then have valproate, excellent against focal epilepsy. Now, it says possible for GTCs, but I can tell you that more times than not, this medication is excellent in the treatment of generalized epilepsy. It is also effective against absence seizure, and there is a possible effectiveness with individuals with myoclonic epilepsy. As I mentioned before, this medication has a lot of downsides. One is the weight gain. Two, it can cause hirsutism in females. Three, it also can elevate the liver function and cause transaminitis. It also can not only decrease the platelets, but also can render the platelets ineffective. So you do need to do frequent blood monitoring when patients are on this medication. And if they do develop any of those conditions, then they need to get cross-titrated to an alternative anti-seizure medication. Again, it's an excellent seizure medication, and it is still widely used. The next three medications, not used very commonly. They have a very narrow utility, as you can see on this slide: tigabine, vigabatrin, and stiripentol. Stiripentol, although approved for the treatment of seizures, really the effectiveness on any one specific type of epilepsy is unknown. With the vigabatrin and the tigabine, they are more focused on treating focal epilepsy, and not so much with generalized absence or myoclonic epilepsy. Now, under the category of fructosamines, we have topiramate, which is an excellent anti-seizure medication if patients can tolerate it. The biggest side effect is cognitive impairment. It's also called dopamine, because people, not dopamine, they also call it topiramate, because it makes them feel stupid. Patients will tell you that they're forgetful, they can't do their normal cognitive functioning. And it is unfortunate because, as you can see, this medication is very effective for focal and generalized seizures, not so effective with absence, and literature is not really out there letting us know whether or not it's effective against myoclonic epilepsy. Unfortunately, with myoclonic epilepsy, we only have a handful of anti-seizure medications that are effective in the treatment of it. So topiramate also, as you're probably all well aware, can help with weight loss. It also can, if you have a patient with a comorbidity with migraine headaches, you may be able to kill two birds with one stone, in that you're treating the seizures and you also are treating the migraine headaches. And that will help with some of the polypharmacy that we all face. Next three are the N-methyl D-aspartate receptors. There is only one under this category, and that is felbamate. Felbamate first made its presence in the 1990s and was quickly taken off of the market because of patients developing in post-market analysis were developing aplastic anemia. And so it was taken off the market, then it was put back on the market because this was a game changer, whereas all of the older ASMs were either losing their effectiveness, we didn't have a large choice. And when felbamate came out, it really made a huge difference on quality of life and being able to adequately treat persons with primarily focal epilepsy, which is what it's been approved for. However, when it was put back on the market, it did have a black box warning, still does. Back then, we had to have a signed consent that they understood that, yes, it could treat your epilepsy, but this is one of the big side effects that could potentially happen to you. And then it was mandatory that we follow their white blood cell counts every 2 weeks. And of course, if there were any signs of neutropenia or leukopenia, I should say, then you could either send them to a hematologist oncologist for further workup or cross titrate them to an alternative medication. You still see patients who have been on it, but it's probably because they have been on it since the 90s and they have been stable from a hematological perspective. And so we have just continued to monitor their white blood cell counts and have continued them on the medication. We do not use this in the treatment of absence nor myoclonic epilepsy. The next medication, primapinil, which is an alpha amino 3 hydroxy 5 methylsulfoxazole for propionic acid receptor. Definitely cannot say that 4 times quickly. But primapinil is another excellent GTC. It's an excellent anti-seizure medication. It is very helpful against focal, GTC, and myoclonic epilepsy. The utility in those individuals with absence seizures is essentially unknown. But again, this is one of the few medications that we have in our arsenal to treat myoclonic epilepsy. The downside to primapinil is that you should avoid giving this medication in individuals with depression or have psychiatric comorbidities. It can heighten the depression as well as heighten whatever psychiatric illness they are experiencing. So definitely should be avoided. Now, in our last category, which is the other category, we have medications such as brivaracetam, levetiracetam, rifampicin, cannabinol, and fenfluramine. I'll start off with fenfluramine because, as you can see, underneath each of the major categories of epilepsy, essentially this medication, it says unknown. That is because fenfluramine, which is the old fen-phen at a lower dose. If you recall, fen-phen first came out onto the market as a medical weight management medication. It was at very high doses. Then the medication was taken off of the market because it was causing all types of cardiac arrhythmias and cardiac issues. It was then reevaluated at lower doses for its effectiveness against a very specific syndrome called Dravet's syndrome. Now, children with Dravet's syndrome can present with seizures, but generally there is a degradation of intellectual capability and speech and motor capabilities. It's a progressive disease, and fenfluramine has been a game changer if the diagnosis is made early on in preventing the slippery slope that Dravet's can cause. But generally, fenfluramine is not prescribed in other types of epilepsy. So brivaracetam and levetiracetam are basically from the same family. Brivaracetam does not have as much of the nasty side effects as levetiracetam as far as mood, altering of mood, creating more depression, agitation, and sometimes aggressive behavior. Both brivaracetam and levetiracetam are very useful for focal epilepsy. The The usage of brivactam is unknown with generalized tonic-clonic seizures as well as absence in myoclonic epilepsy. However, there probably will be more research studies looking at its effectiveness. More specifically, I would say in the generalized tonic-clonic category. Now, levetiracetam definitely has effectiveness with generalized tonic-clonic seizures. It has now become the mainstay, if you will, of individuals presenting with first-time seizures. If they are treated for their first seizure, it has multiple formulations, including liquid, IV form, and of course, pills. There is some possibility that levetiracetam is useful for absence seizures, and again, very useful for those individuals with myoclonic epilepsy. Rufinamide is a medication that has been out for quite some time. You do not see this medication used as a monotherapy or initial when patients are initially started on anti-seizure medication. This is a very good add-on medication for those individuals with intractable or refractory epilepsy. Very useful with individuals with focal epilepsy. There is some possible usage in individuals with GTCs. I can tell you that it is used in individuals who do have GTCs along with focal epilepsy, and it does seem to be somewhat effective. There is not enough literature out there that would enable us to prescribe this medication for absence or myoclonic epilepsy. Now, cannabidiol is a derivative of cannabis. It's in a oil liquid form. It unfortunately, although it is excellent in the treatment of individuals with intractable focal epilepsy, especially in those individuals who have Lennox-Gastaut syndrome. Lennox-Gastaut syndrome is a very specific epileptic syndrome that they present with multiple seizure types and seizure focuses. They also usually have some intellectual disabilities and may also have some comorbid psychiatric issues as well. Cannabidiol is an excellent choice for those individuals. It is weight-based, dosage is weight-based. And unfortunately, as I said, the downside to this medication is that it has a very horrible taste, but it can get masked somewhat with either very sweet, like chocolate syrup, or very sweet food products, or high-fat products. Now, it usually is better metabolized when consumed with a high-fat diet. And so that concludes the section on our discussion regarding medical management of individuals with epilepsy. I just want to spend a few more minutes talking about brand and extended releases. So every single one of our anti-seizure medications have both a brand name as well as a generic formulation. Not all anti-seizure medications have extended release. The more popular anti-seizure medications that have an extended release are lamotrigine, levetiracetam, Depakote, carbamazepine, and more recently, lacosamide has come out with an extended release medication called Metoprolol. Now, what are some reasons for using brand name only? Now, most insurance companies want us, unless the medication is in a patent, they want us to use generic medications, and for obvious reasons. They're cheaper than brand names, and so we're usually are forced by most commercial payers, including federal and state programs. So their Medicare and your Medicaid programs are looking for generic formulations of the medications. However, There are subtle differences between brand name medications as well as generics, and I'm quite sure you're well aware of this. Many times it's some of the additives. The main molecule of the drug stays the same, but it's what they add to it that may render the primary substance, if you will, of the medication inactive. And you won't know that until you switch a patient from a brand name medication to its generic partner, only to find out that it's causing more seizures. And in fact, in individuals who are very stable on brand name medication, and then we switch them over to a generic formulation, then all of a sudden they're having multiple seizures. The first thing you're going to have to think about is, gee, I switched from brand name into this generic. That's probably the cause. And then if you put them back on the brand name with getting a prior authorization from the insurance company, and then indicate in the prescription that this patient can only take the brand name formulation of the medication. I will also tell you that this holds true with manufacturers. So if you have a generic formulation made, let's say, of Keppra, and I don't know how many manufacturers make Keppra off the top of my head, but I have particular patients who can tolerate one manufacturer, but they can't tolerate the other manufacturers. And so that's another note that I will put to the pharmacy, that the patient can only have this Keppra made from this manufacturer. So it's just something that you have to be aware of. So that's when I only use brand name. If they cannot tolerate anything, we put them back on the brand name. We get the prior authorizations from the insurance companies. Now, why do we use extended release? I kind of mentioned this earlier on in this presentation. Well, I mentioned it under the guise of intolerable side effects. So if you have somebody, oh my gosh, I take the medication and then I just sleep throughout the day. I can't function. And then I take it at night, but I am sleeping very well. Well, if you give them an extended release BID dosing, now the medication, when you look at the pharmacokinetics, is a slower release throughout the day. And that sometimes will help with that intolerable side effect of the fatigue and the somnolence. Now, the other reason to do it is compliance issues. They forget to take the medication. Many of these patients have very poor short-term memory. They have a lot of cognitive issues, some from the medication and some from the amount of seizures that they have experienced. And so by putting them on an extended release and just giving them their medication at night may also improve compliance. And one thing before I switch gears that I wanted to mention, and this is in regards to the therapeutic drug levels. When you're getting or obtaining therapeutic drug levels, you either, if they're on the immediate release medications, which is the majority of the medications, they're on the immediate release, I either ask them to have their labs drawn before they take the morning dose of their medication without delaying that timing, right? And, or they can go late in the afternoon as the medication from a pharmacokinetic standpoint is at its trough. Alternatively, if patients are taking extended release in the morning, I will ask them to get their labs drawn prior to taking the drug first thing in the morning. If they take it at night, I ask them to have their labs drawn late in the afternoon. I usually say, go to Quest and get your appointment, the latest appointment that you can get with Quest. That's the appointment that you need to get. So that's a little bit about therapeutic drug levels. As I mentioned before, I either use those to allow me to see if I can go up on dosages, or in fact, are you taking the medication? I wish to thank you for your time and attention, and I hope that you have found this presentation very helpful. You have my email address, and I really do value any feedback that you can give regarding this presentation or any other future presentations you would like to hear. Thank you and have a great day.